moving on to the next topic, I would like to call upon the chairpersons, Dr. Satish Ramana KS, who is the consultant physician and diabetologist at Harsha Hospital, Bengaluru, and Dr. Krishna MV, who is the consultant physician, Professor, Department of Medicine, RR Medical College Hospital, Bengaluru. We welcome you on stage, doctors.
Good afternoon. It's my pleasure to introduce Dr. Basavanagowdappa, who is a senior consultant physician, diabetologist, and Vice Chancellor of JSS Academy of Higher Education and Research, Mysore. Over to you, sir.
Good afternoon to everybody. What a session we had just before lunch. Yoga person made us to think less and quietly practice and take care of yourself. Followed by a very, very rapid fire session on erectile dysfunction by Bobby Matthew. And of course, working lunch and gestational diabetes symposium. Today, I'm just taking over 15 minutes of time on this particular issue where Manohar has made us all to start thinking about this molecule, mineral, which is forgotten by every one of us. You routinely measure HbA1c, lipid profile, kidney functions, and everything else, and screen for complication. But one of the most important intracellular mineral is insufficiently recognized by every one of us. It is a high time that we need to understand what all this does in the human health, especially in the diabetogenesis and its complications. A simple mineral, but has a major impact on the glycemic control, fewer complications, cardiometabolic protection, renal benefits, and overall improved diabetes outcome. Let me convince you in the next 12, 13 minutes about what we need to know. The title of the talk is, Are we missing one of the simplest opportunities to improve diabetes outcomes? I would like to ask the audience, how many of you routinely measure serum magnesium in patients with uncontrolled diabetes? I'm not talking about all diabetics. How many of you really measure magnesium? None of. Okay, I was also not measuring it in many, but till I came to know about it when I started measuring only in the selected individual. Let us learn today. But having not got an answer for the first question, there's no question of answering the second one. How many prescribe magnesium supplementation based on the evidence rather than symptom alone? Of course, some of you might have prescribed, but let me take you through. The magnesium is not merely another electrolyte. It is an important metabolic regulator influencing every stage of the diabetes continuum. Dear friends, why should we care about magnesium? This is the second most abundant intracellular cation. That is very, very important thing that we need to understand, which we less care about. It works as a cofactor in more than 300 enzymatic reactions. Phenomenal role it plays. It is essential for insulin secretion as well as insulin signaling, and regulates glucose transport as well. So obviously it has a great connection in terms of diabetes. It influences vascular functions, and how common it is? Last decade was a decade of vitamin D. We all jumped upon to understand, and there was startling news even among the doctors. When you check the vitamin D, it was deficient in 80% of the people, and that is true. Not that everybody needed a supplement, but if you look at the normal values which were set for the Westerners, Europeans, when we apply the same to Indians, a startling deficiency was there. Similarly, when the random check was done on magnesium levels, it is startling phenomenon, startling evidence that 25 to 40% of the people are having critical deficiency of magnesium. So take home point from this slide is magnesium deficiency is very common but frequently unrecognized. Now what is the normal magnesium level and what should we bother about trying to know that when you check it you should know what is normal and how do you grade the severity of deficiency. The normal values are ranging between serum magnesium 1.7 to 2.4 milligrams per deciliter. And severity can be graded into normal, mild, moderate, and severe. If it is less than 0.9 milligrams, it is severe deficiency. 0.9 to 1.1 is moderate, and 1.2 to 1.6 is mild deficiency. Anything above 1.7 up to 2.4 is normal. Now, what happens? What is the real role of magnesium in pathophysiology of diabetes? It is a very interesting phenomenon. Whenever there is a magnesium deficiency, by whatever way it happens, it reduces the insulin receptor activity, it impairs the tyrosine kinase activation, so it increases the insulin resistance and also reduces the GLUT4 mediated glucose uptake. So naturally it produces hyperglycemia. Hyperglycemia will produce hyperosmolality in the urine. It drags away more and more magnesium. It sets a vicious cycle. So clinical studies of serum magnesium and B12 was done in elderly population in our own geriatrics department. Especially they looked at those who are on chronic PPI ingestion. There were startling pictures. One of the most common cause for magnesium deficiency is use of proton pump inhibitors for long term, especially in elderly. So let us understand very critically about causes of magnesium deficiency. What all are known to cause, so that we put them as a basket of high-risk individual where you must check magnesium. Today I didn't see anybody raising hand about how many checked magnesium in their diabetic patients. None of you checked, including me. I was not practicing to check magnesium till Manohar made me to think about magnesium and made me to talk about this also in some of the previous platform as well. He started talking about magnesium last 1 year in 3-4 platforms. It is amazing situation to understand. Many symptoms we need to understand that they are contributed by magnesium deficiency. We don't recognize that. We harp on diabetes control. We look at something else, vitamin E deficiency causing cramps in the muscle and so on. Friends, believe me, these are the clinical situations which can cause magnesium deficiency. One, poor control of diabetes, magnesium deficiency because of hyperosmolality in the urine. It takes away more and more magnesium out from the body. It sets a vicious cycle, as I told you earlier. The second is, whenever somebody is on osmotic diuresis or diuretic therapy, loop diuretics or thiazide-like diuretics, friends, it will take away some magnesium from the body in the urine. Excessive alcohol usage and poor dietary intake of some of the principles, I'll tell you, simple dietary principle will contain magnesium in my next slide. GI losses, chronic diarrheas, and chronic use of proton pump inhibitors. There are so many people who have become addicted to PPIs. You tell them, please stop it. They say, okay, I will try. But they come back to you and say, I cannot stop one day. There are so many patients who have become dependent on PPIs for a long time. So, who are the risk patients? Anybody who is a long-standing diabetic, at least check once magnesium. Especially so when they are uncontrolled, in spite of your optimum therapy efforts. Elderly patients, those who are on polypharmacy, especially those who are taking diuretics and poor glycemic control, please keep them as a high-risk group which need at least one level of magnesium assessment. So multiple factors often coexist together. He is elderly, he is uncontrolled diabetic, he is on multiple drugs including diuretic. He is a sore candidate where you must check his magnesium, especially so when he has symptoms. When I learnt about this, I was curious to know. We give SGLT2 inhibitors, they throw away the glucose in the urine. And we talk about osmotic diuresis will drive the magnesium out of the body. But I found a different picture. I asked a question about what will happen to magnesium deficiency when you are giving SGLT2 inhibitors. Because everybody, though you tell the patient not to check his urine sugar, he walks in, sir, 2% aita. You tell them that when I am putting you on SGLT2, don't bother about urine sugar, but still they get it checked. They come back to you, sir, urine sugar has increased. It is an interesting phenomenon. Normally, when a glycosuria occurs, it induces the osmotic diuresis. When osmotic diuresis is there, it is supposed to take away more and more magnesium from the body. But look at here. Glycosuria in SGLT2 therapy, not otherwise, improves the glycemic control and enhance renal magnesium handling. And here, on the contrary of expectation, SGLT2 therapy is shown by studies that marginally it can improve the magnesium levels. So this is the contrary to expectation. So don't be worried about prescribing. Okay, what are the clinical consequences? Let me talk about metabolic. It increases the insulin resistance, poor glycemic control, and in neuromuscular, it is supposed to produce cramps as a common symptom, weakness and fatigue as a very, very common symptoms, and cardiovascular, it can enhance hypertension, endothelial dysfunction can be augmented by magnesium deficiency, it is pro-arrhythmogenic situation, and increased cardiovascular risk for events. On the bone health also, it has a role to play, and it produces demineralization in the bones. So take-home point from this slide is magnesium deficiency has a far-reaching clinical consequences that impact quality of life and long-term outcomes. What about diabetic complication? You name a complication, there is a role of magnesium. Not just a statement made, there are studies which have proven, including retinopathy, nephropathy, neuropathy, cardiovascular disease, heart failure, increased mortality overall. So key message is low magnesium is more than a laboratory abnormality. It is known to contribute for progression of diabetes and its related complications. Friends, what does the evidence show? It is not just a statement based on one single study or a personal experience by few patients. The lab data shows, or the literature shows, randomized trial have suggested HbA1c is higher in all those who have got a low magnesium. Greater insulin resistance is proven with evidence. Higher risk of incident type 2 diabetes and increased cardiovascular events. So when you replace that, surely magnesium supplementation was proven to show significant decrease in fasting glucose, significant improvement of insulin sensitivity, variable effect on HbA1c. Okay, improvements are modest but clinically very, very meaningful in a given patient. So there is a growing body of evidence that supports the role of magnesium as an important determinant of glycemic control and metabolic health in diabetes. Friends, then does it mean that we should measure magnesium in everybody? It may not be practicable to ask everybody to get it done, but do measure in these situations. These are the so-called high-risk group for possible magnesium deficiency. One, anybody in spite of your optimal effort of therapy with combination of insulin, OHS and so on, still poorly controlled, please check. Are we dealing with hypomagnesemia, which is causing more insulin resistance and effect on insulin release mechanism failure? Recurrent hypoglycemic events, brittle diabetes, check magnesium. Muscle cramps and weakness, very common in some of the elderly patients, check magnesium in them. Cardiac arrhythmias, recurrent. Chronic diuretic usage, at least once, those who are in polypharmacy, especially with diuretic therapy, check magnesium once. Proton pump inhibitors, who are not inevitably continuing PPIs, diabetic kidney disease and recurrent hypokalemia and hypocalcemia. If you have got any of these situations, you must check magnesium. It may be playing a role. But remember, when you are checking magnesium, you are checking only the 1% of the magnesium concentration in the body, that is in the serum. 99% of magnesium is in the cell, inside cell. So what we are measuring is only 1%. So normal magnesium doesn't rule out total body hypomagnesemia. So what you have to remember is, just don't interpret the result, look at the patient's profile. If somebody has muscle cramps, severe generalized weakness, maybe 1.7 milligram is the magnesium level, he is a candidate who may need replacement. So clinical judgment is important than given value, because we are only measuring 1% of the total body magnesium in the serum. So what are the magnesium supplement? Always food first, natural supplement. So what are the things which will give you more magnesium naturally from the food? These are the magnesium rich foods: nuts, seeds, legumes, whole grains, and green leafy vegetables. Or a whole balanced diet will give adequate magnesium for anybody per day. But beyond this, in a critically low magnesium or moderately low magnesium, who is not on diuretics, who is not on PPI, you need to supplement the magnesium apart from advising about diet. So there are 3 magnesium salts available: citrate, glycinate, and the chloride. I'll talk to you. So clinical case, one simple case, a 58-year-old man, 10-year-old duration of diabetes, A1C 9.2%, and he complains of muscle cramps and hypertension. He was on metformin and hydrochlorothiazide, and his serum magnesium was 1.5. It is just mild hypomagnesemia. So clinical question is magnesium deficiency contributing to the poor glycemic control? Probably yes. Should magnesium be corrected? Let me see, we can answer. Should medication be revised? Certainly. He is on thiazide. He is a candidate where you must stop that. Stop it, give him oral, the dietary advice about magnesium-rich diet, and he will come back to normal magnesium. His diabetes may be controlled. So that is the answer for that. So magnesium prescription is not to be jumped up. You review his medication, correct it. Moving from awareness to action, anybody in those lists which I mentioned, identify those high-risk patients, measure the magnesium when clinically indicated, correct reversible causes like stopping diuretics, stopping PPI, and so on. Improve the dietary intake, advise them a lot of nuts, legumes, and green leafy vegetables. Supplement when appropriate, monitor response and renal function, and reassess the glycemic control and symptoms. Take-home points is magnesium deficiency is common in type 2 diabetes. It contributes to insulin resistance and worsens glycemic control. Low magnesium is associated with several diabetic complications, and routine testing is not necessary for every patient, but high-risk patients, please check it once. Dietary optimization is the fundamental rule. And then revise his medication. Then prescribe all these available formulations in the pharma industry. I just made an effort to what all kind of magnesium preparations are available in the market. All kind of salts are available: citrate, glycinate, oxide, chloride, lactate, sulfate, so on. When magnesium was thought about, we were also always looking at obstetricians who used Maxalf for eclampsia management, and surgeons who use Maxalf dressing. Okay? And then cardiologists sometimes for arrhythmia correction. Beyond this, physician never thought magnesium has to be looked into. Thank you, Manohar, for giving this topic. I am sure all these are possible prescriptions. First, revise the drugs, especially diuretics and PPI. Second, advise him about the dietary source. Third, measure in all high groups. If it is moderate to severe, please give any one of them of your choice, whichever company comes and promotes. I'm thankful to you. This is my conclusion. Okay? So magnesium may be a small mineral, but it is important on a metabolic health is sustainable, substantial. The future of diabetes care is not just prescribing and newer molecules to control diabetes. Look into, are we dealing with magnesium deficiency? Can we correct it? Without advancing to a new molecule, he may get his diabetes controlled and other symptoms corrected his complications can be overcome or prevented. Thank you.
Excellent presentation, sir. You highlighted the role of magnesium in the management of diabetes. Thank you, sir.
Any questions? I'll be able to answer them if. Yeah, please.
Ladies and gentlemen, we were classmates. I keep telling him his date of birth is 29 February. Every 4 years he becomes 1 year old. Every year I become old. So you can imagine. Great job you did. I'll just add some clinical pearls here because Manohar asked me to be a part of the national group for this. The first thing is, as he said, where do you find magnesium? Inside the cell. 70% of your body magnesium is in your bone. And whenever you need magnesium, bone gives it. Down the road in 3 months, 6 months, what happens, you know. So today, if you don't add magnesium to calcium and vitamin D, osteoporosis cannot be stopped. First clinical pearl. Second one, between the first choice of magnesium supplement is food, second choice is drugs. What do you think is the right one? Food. You know, to get magnesium from seeds and nuts, it is Herculean task because they don't give it up so easily. You have to overnight, you know, all those traditional things that we do. The best thing, if you suspect significant magnesium deficiency, please close your eyes and give them supplements for 1 or 2 months. The third clinical pearl, magnesium deficiency doesn't occur overnight. It doesn't occur over months. It's over 6 months to 1 year. And magnesium replacement doesn't occur overnight. It has to be for a long period. Don't give them for 15 days and then say, eat nuts. They go nuts. Thank you.
Thank you for excellent additional points that you have driven.
Of the supplements, the various forms of supplements, which is the best and
The selection of the molecule to be prescribed is dependent on the bioavailability, also coexisting kidney disease, and eGFR has to be checked. The selection depends on the clinical indication. If it is pure magnesium deficiency correction, any one of those salts are enough. But if it is injectable to be given, especially in eclampsia and cardiac arrhythmia, it is injectable, it is magnesium sulfate. Otherwise, all those are, any one of them could be enough to overcome the deficiency.
Just to add to what sir said, magnesium glycinate is the best bioavailability. So generally we speak about magnesium glycinate as the best choice for supplementation. Yes, sir.
High absorption and well tolerated.
Yes.
Gentle on the stomach. The
last choice is magnesium
The
oxide.
second one, the glycinate, is the most stomach friendly and well absorbed.
See, the last choice is oxide.
Okay.
The best choice is any one of them, provided they have the pockets.
Correct. Thank you.
Thank you.
Thank you so much, sir.